Hey, so let's get started. Some more antianginals. We're going to talk about beta blockers. This is a very brief overview of beta blockers. Next semester, we'll go in a lot of more in-depth about it. So just take a listen, and we're going to talk a little bit about beta blockers. They're antianginals also. Okay, let me get my little thing. I always have to look down because I cannot see. Here we go. And let's get started. So beta blockers, the mainstay in the treatment of several cardiovascular diseases. We use them for angina. We'll use them for acute MIs or MIs. Hypertension, we see a lot of people taking beta blockers for their hypertensive issues if they have hypertension, and dysrhythmias. So they're a great drug to be given, and you will see a lot of them given out there when you're in the working world. If you're already nursing, you're seeing it. If you've not worked in an area that there's some cardiac, we know that one of the biggest issues in our country is cardiac disease. You know, we're diabetics, we're heavy, and we have issues with our heart. So we see a lot of people on beta blockers. So LOL, it is one of the easiest ways to identify a beta blocker. There are several out there. They end with the LOL. And I know this is my age, kind of showing my age, is I still say LOL and put the little laugh out loud thing up and all that. A lot of my children go, you're just out of date, Mom. But anyway, LOL is how you remember that. So if you see a drug and it has LOL at the end of it, it should make you think beta blocker. And I thought the elephant was cute. Okay. Antianginal beta blockers. We have atenolol, metoprolol, propranolol, and nodolol. And I'm not good at saying that one. And I don't usually use that. I've used a lot of metoprolol, propranolol, and atenolol. But do you notice that the LOL is at the end of each of those? That's why when you're looking at medications on a test or out there when you're working or on your NCLEX, whichever, wherever, or whatever, when you see LOL, that should make you automatically think beta blocker, okay? So the mechanism of action is they block beta-1 receptors. Now we have beta receptors in our body. We have beta receptors in our heart, and we also have beta-2, which we think lungs. So these receptors and cells are out there. So what happens is we block beta-1 receptors on the heart. And what will happen when we do this, it decreases our heart rate, resulting in a decreased myocardial oxygen demand. Once again, if the heart's beating fast and hard, it's got an increase for oxygen demand. So we want to decrease that oxygen demand. And by doing that, if we give this medication, we can block the beta-1 receptors, and this will decrease the myocardial oxygen demand and increase oxygen delivery to the heart. That is our goal. We need to get oxygenated blood to the heart and decrease that workload. So we want to decrease myocardial contractility. That's what it will do. And that's going to conserve energy or decrease the demand. Once again, I want to say it again. So when I give a beta blocker, what's happening is and we'll go into detail next semester about the beta-1, beta-2s. But right now, all I want you to understand is it's going to block that beta receptor, that beta-1 receptor. We have one heart, always think beta-1 heart. Always think when you see the one, it's a heart. Decrease the heart rate, resulting in a decreased myocardial, a cardiac or heart oxygen demand. So I bring my heart rate down. That is going to slow the workload of my heart, right? And by doing that, it's not going, which needs a lot of oxygen. It's now just going to pump at a lower pace, decreased heart rate at a lower rate. And then by doing that, it's going to increase the oxygen delivery to the blood. So we're able to get oxygenated blood in there. We're not having such a high demand because we've slowed it down. Same with contractility. If we decrease the contractility of the heart, we're going to conserve energy. So if I take a muscle and I go, hoo, 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 that is a huge contractility of that muscle. And I am using and eating up all my oxygen, and it is a lot of energy going in to make that happen. If I can decrease the heart's contractility of going like this, and maybe have it go like this, I'm going to conserve energy that way. And that conserving energy decreases our oxygen level and our oxygen demand. Okay. So I hope that makes sense to you. We'll go on. After an MI, a high level of circulating catecholamines irritate the heart, causing an imbalance in supply and demand ratio and even leading to life-threatening dysrhythmias. So layman's terms, or a little easier said, when you have a heart attack, we get all these catecholamines that are released, and everything gets irritated. The heart's irritated. It's just angry. It's had a major heart attack, an insult, and it's like not happy. And when that happens, there's a big difference in the supply and demand ratio to the heart. There's an imbalance. And when that happens, and that irritated heart's that way and wanting this and that, and it's all off kilter, we will have dysrhythmias. So that's why with an acute MI, we can have dysrhythmias, and dysrhythmias are abnormal rhythms. Our heart is made to beat at a sinus rhythm. There are people that live in other rhythms, but they are controlled by medications and things like that. It's doable. But dysrhythmias, or life-threatening dysrhythmias, or arrhythmias, or abnormal heart rates or rhythms, can create life-threatening issues. So beta blockers can help stop that by what they're doing. Beta blockers block the harmful effects of the catecholamines, thus improving the survival after an MI. So what we do is when people have heart attacks, we will prophylactically, the doctors will prophylactically, physicians order them beta blockers. We'll give them a beta blocker. We have proven, research has proven that by doing this, it is going to block the effects of those catecholamines, and that will improve the survival after an acute MI or heart attack. So really quickly back, we're going to block beta-1 receptors on the heart with the beta blockers as our mechanism of action. We're going to decrease our heart rate, resulting in a decreased myocardial oxygen demand. So we're going to decrease the rate. The rate's going to decrease. We're going to bring that oxygen demand down, and that's going to increase oxygen delivery to the heart, and that's what we want. We're also going to decrease myocardial contraction. And by doing that, we're going to conserve energy, and that decreases the demand. So the more I'm going at it, the more oxygen I need. So I need to slow the rate and the pump down so that I can conserve energy and get more oxygenated blood to that, decrease that demand and get that oxygenated blood. Then after an acute MI, just remember, we have these circulating catecholamines that irritate the heart. They just, that heart is like, it doesn't know what to do, causing, and this is an imbalance. And because of that imbalance of supply and demand for the heart, it leads to dysrhythmias. We start to have all these issues go on with the heart. It's like, I can't do it, and we'll have these dysrhythmias. So the beta blockers mechanism of actions will help block those catecholamines, and by doing that, it improves the survival of an acute MI. So prophylactically, they might not have any dysrhythmias, but prophylactically, if they've had an acute MI, a physician will order usually a beta blocker to be given to them post-MI. So they go home on them. Okay, indications. If you have angina, if you have hypertension, so it's an antihypertensive. If you're having cardiac dysrhythmias, we can give you a beta blocker. That's a reason to. It's cardioprotective effects, especially after the MI, acute MI, and that is blocking those catecholamines. And some use for and we also use beta blockers, just an FYI. There's always, drugs do so many different things. You know, we focus on that one main, but they do different things. But it is used for migraine headaches, essential tremors, and stage fright, which I think is kind of interesting. But what is it going to do? Decrease all those beta 1s, right? Block beta 1 receptors. Kind of makes sense if you think about it. Contraindications for beta blockers: systolic heart failure, serious conduction disturbances. We got to be very careful when we use beta blockers. If we have bronchial asthma because of any level of blockade of beta 2 receptors, it can promote bronchoconstriction. Big words again, kind of a big thought. So if we have bronchial asthma, and because of the level of the blocking of beta 2 receptors, if we gave a beta blocker, we can promote bronchoconstriction, and that would be bad. That would involve our breathing, right? Our oxygenation, perfusion. So look at the beta 2 there. You notice that when we looked at the first one, we were looking at beta 1. When you see beta 1, this is a basic, I'm not going into real detail with this, but when you see beta 1, we have one heart. When you see beta 2, we have 2 lungs. And that's kind of a way to understand, remember that. Diabetes, it can mask hypoglycemia-induced tachycardia. So if they have diabetes and we give a beta blocker, we can create a lot of issue with that. So we don't want to do that. So if they're a diabetes mellitus, we need to think about the beta blockers. Peripheral vascular disease may further compromise cerebral or peripheral blood flow. So those are contraindications to kind of make yourself aware of, because you need to kind of know that. So if you're getting a health history or you're assessing your client or your patient and you have these, you need to think, does this patient need to be on a beta blocker? That is a thing that you would then ask the physician, hey, my patient or client has these issues. It's definitely for you to be that advocate and thinking. Okay. Beta blockers adverse effects. So cardiovascular, it can cause bradycardia. It can slow the rate down and we can be bradycardic. If we're bradycardic, where we have a lower heart rate, right, below 60, we can become hypotensive. It's going to help with hypertension. We give it for hypertension. So we can have hypotension, bradycardia, and we can actually have an atrioventricular block, an AV block. So what we can do is create a electrical issue with our heart. So bradycardia for the cardiovascular, hypotension, and atrioventricular block, which is an AV block, and we will go over rhythms at another time. But just know that beta blockers can create issue for the heart in the cardiovascular system with this. Metabolic. It can cause hyperglycemia, hypoglycemia, and hyperlipidemia, dealing with the different body systems and the adverse effects. Central nervous system, we can see dizziness, fatigue, depression, lethargy. And then we also can have some other body systems or issues, and that's impotence. And I'm going to tell you, with impotence, younger men that have had heart attacks or have hypertensive issues and are put on beta blockers, a lot of the hypertensive medications can cause impotence. So it's very difficult to get a younger man. And I'm not just isolating older and younger, but a more sexually active individual to take these beta blockers because it can cause impotence, wheezing, and dyspnea. Okay. These are some of the beta blockers, and they do different things. So, the beta blockers. So atenolol we can see it as tenormin, and metoprolol is Lopressor or Toprol XL. Now, these 3 drugs are drugs that you see a whole lot out there in the clinical world. So they're drugs to kind of create a drug card if you're in school, if you're not, and just know you're seeing it. But these are the names of tenormin, Lopressor, Toprol XL. They're cardioselective. So they're beta 1 receptor blockers, adrenergic receptor blockers. So we're looking at the heart. They're going to block that beta 1. And when we block the beta 1, what do we know it's going to do? It's going to it's going to decrease the rate. It's going to decrease the contractility and hopefully decreasing the demand and the energy levels so that we can increase the oxygenation of the heart. It can be given, these drugs can be given prophylactically to treat angina pectoris. So if we have a person with chest pain, we can use this prophylactically, and we can use the use of atenolol after an MI has been shown to decrease mortality. Once again, that's the tenormint. Why? And the why is because it blocks the catecholamines that are given off after a heart attack. Heart's all irritated, and it's going to create a bunch of, its supply and demand is out of sync. And because of that, it can create lethal dysrhythmias and cause the patient to cardiac arrest again, or go into lethal arrhythmia and not come out of it. So that's why it will decrease mortality. So most patients that have had a heart attack will be on a beta blocker post. Okay, a patient who has had an MI, let me move me out of your way so you can see the question, is taking a beta blocker. What is the main benefit of beta blocker therapy for this patient? So he's had a heart attack, he's taken a beta blocker. A, vasodilation of the coronary arteries. B, increased force of cardiac contraction. C, slowing the heart rate. Or D, maintaining an adequate blood pressure. The answer is C. We're going to slow the heart rate in patients with ischemic heart disease. This reduces the oxygen demand and allows the coronary arteries time to fill with oxygen and nutrient-rich blood. Beta blockers also block the irritating effects of circulating catecholamines on the heart. So we've said it once before. I do want to go back, see if it can take me back. So it's not, the beta blockers are not going to dilate the coronary arteries. What dilates our coronary arteries are the nitrates, right? We just talked about those in another video. So it's not going to increase the force of cardiac contraction. It's going to decrease the force of cardiac contraction. It is going to slow the heart rate, and that's why that's the correct answer and the reason why. And it doesn't maintain an adequate blood pressure. It's not the benefit. It's, if anything, it's going to make them a little more hypotensive. So we have to be very careful, but it will decrease the blood pressure based on what it's doing. So C is the correct answer. These are the videos. This video consists of very few slides for beta blockers, but I want you to just remember that we give them, if it's a beta 1, we're thinking heart. If it's a beta 2, we're thinking lungs, and we go into other drugs down the road with the beta 2s. And we know that by giving the beta blockers, we're decreasing the rate. So we're bringing the heart rate down. We're decreasing the contractility. So we're going to decrease the squeeze or the pumping action. And by doing those two things, we decrease the energy and oxygen demand of the heart. And when we do that, then the blood, oxygen and nutrient-filled blood can go in and actually oxygenate the tissue of the heart. And we can hopefully save patients by utilizing these medications. The other thing a beta blocker always does, or can do, I should say, is if they have had an acute MI, all those catecholamines are released and it causes an irritated heart. You'll hear nurses and doctors say when they have arrhythmias, they'll go, oh, that heart's irritated. And what we need to do after that acute MI is hopefully the physician will prescribe a beta blocker, because it has been proven that it blocks the catecholamines, which causes that irritation, and hopefully will prevent the patient or client going into lethal dysrhythmias. I hope this helps.